So, hello everybody. My name is Dana Stoian. I'm professor of endocrinology at the University of Medicine and Pharmacy in Timișoara, Romania. I'm also part of the county hospital in the same city. Last but not least, I am part of the Ultrasound Learning Center in Timișoara, which is affiliated with the World Federation of Ultrasound Learning Center throughout the world. And I would like to thank VUMEDI for the invitation to present our latest research that were also presented at the last European Thyroid Association meeting, which was held at the beginning of September in Athens, Greece. And since we are endocrinologists, it's my pleasure to share with you my research together with my younger collaborator, Dr. Borlia, who is also endocrinologist with the same affiliation as myself, in respect of the role of contrast-enhanced ultrasonography in the differential diagnostic of diffuse thyrotoxicosis, which is a very important topic for us endocrinologists. Why is it important for us endocrinologists such a topic? Because actually we are facing different type of thyroiditis, in which part of them, or some of them, at least from part of their evolution, are associated with hyperthyroidism. And besides the typical Graves, which is induced by TSH receptor antibodies, and this is the typical most frequent type of hyperthyroidism, meaning hyperproduction, we have a lot of other types of hyperthyroidism, transient usually, like in hashitoxicosis, subacute thyroiditis, painless or silent thyroiditis, postpartum thyroiditis. Last but not least, drug-induced by use of amiodarone, lithium, and especially immunotherapies for different type of malignancies. We are facing a different and increased variant of hyperthyroidism, which are not hyperproduction, but destruction. Because in the hyperproduction variant, in which the typical example is the Graves' disease, there is also the destructive variant in which the normal thyroid structure is replaced by different either fibrotic or fibroblastic pathology, like in subacute variant, or is really a destruction by itself, where we are taking into consideration immunotherapy, amiodarone, lithium, or even radic-induced thyroiditis. Why is this differential diagnostic important for us? Because in destruction, we are controlling the aggression by itself, usually with corticoids or with, in milder forms, with non-steroidal anti-inflammatory medication. And in hyperproduction, we are controlling the hyperproduction. And this is one of the examples of different anti-thyroid medication like carbimazole, thiamazole, and there is also the propylthiouracil on the market. And currently, the standard of the differential diagnostic between hyperproduction, which is this case, the Graves, and no uptake, the destruction, like in this image, is by nuclear imaging, which is higher cost, radiation exposure, time consuming, and you have to think about how many hospitals and how many patients can be really referred instantly to nuclear imaging. And when you are considering not a major county hospital, then you have to think that something else can be done. And what is the something else? It's the proposal of ultrasound, and we see in some next examples. Of course, you can say Doppler is useful in the typical diagnostic of Graves' disease, and this is clear that you can use conventional Doppler for measuring and actually not measuring, but seeing high flow rates. You can see even if we have an onwards or towards to the transducer flow, but actually it's not important. In this example, you might say, okay, high increased vascularization, and in such a case, you are expecting a hyperproduction. Of course, you can measure it, and this is a typical example of normal superior thyroid artery values, and there are data in the literature. I will show you in the next slides how are the values. And actually, whenever you have such a huge value of end systolic speed, like over 50 centimeters per second, this is re-emphasizing that you have an overvascularity in front of you, highly suggestive for hyperproduction, but there is not always the same. The proposal of contrast and what brings contrast new or different in respect to conventional Doppler, it's actually that you will see the blood supply in the entire tissue, and you will get to see and to imagine the vessel geometry, the vascularity of small vessel. It's about the spread of the contrast agent in the vascular bed of the organ. It's about capillary flow, and it's actually about parenchymal perfusion, which is a much more deep inside the pattern of tissue activity than with the conventional Doppler or even with a spectral one. Currently, the different types of contrast agents are proposed. One for image only, it's vascular system imaging after IV injection. It's freely transported in the blood. It is retained in the blood system, is not organ specific. Whenever you use the transducer on, you will get to see the contrast. There are some specific proposed tissue contrast agents, which actually, as from the research point of view, are aimed to target and to deliver through the bubbles specific medication on target organs. But this is about research. This is what we are currently using. And actually, we are using a special characteristics of the bubbles, because there is the behavior of the microbubbles as a function of the insonation pressure delivered by the transducer, and the bubbles do behave different according to which type of pressure they are primarily exposed to. So when you are using too high pressure, you have to have a low mechanical index not to destroy the bubbles. Whenever you have the pressure, too high pressure, so too high pressure, this is mechanic index and acoustic pressure. So too high pressure and mechanic index will destroy the bubbles. Too low pressure, we have a backscatter that will alter the image, and there is a special window of diagnostic in which actually you are just using the insonation and the difference in shape of the bubbles when exposed to the pressure made by the transducer, and you have a signal increase of the bubble movements and the signal decrease of the tissue that is below. From the thyroid point of view, 1/3 of the microbubble solution is used, followed by 10 cc's of serum. You have to have, as mentioned before, low mechanical index. You will have to have a clear field of view. Thyroid capture time will actually use a continuous loop up to 3 minutes, although in the first meeting you have the needed informations. And proposed analyses that are currently used are either qualitative or quantitative. I will show you some images. There are clear data about the valuable info added by contrast in respect of liver, pancreas, retroperitoneal, bile duct, spleen, breast, and especially breast sentinel lymph nodes currently. And there are limited data about the thyroid by itself, some data about thyroid nodular disease, but very few about diffuse thyroid disease. The last contrast enhanced guidelines were published by the European Federation of Ultrasound in 2017, but actually is not mentioned the diffuse disease, but only the thyroid nodular disease. And its respect, or by that time was research future proposed, although in the meanwhile, there are valuable data about the contrast use in nodular thyroid disease as a risk upgrader, not a risk downgrader. And of course, we have multi-parametric when we think about ultrasound evaluation, and this is one of our previous published work being like that. So step one we all do is grayscale. And whenever we have hypoechoic and usually either polylobulated or inhomogeneous structure, you think about diffuse thyroid disease. If you don't have hypoechogenicity and you have normal volume and normal antero-posterior diameter less than 2 centimeters, you will say everything is normal. Whenever you have the incidental diffuse thyroid disease or you have a symptomatic patient in front of you with a conventional grayscale re-emphasizing that you have a diffuse thyroid disease in front of you, you can go to the next step, which is not necessarily the color Doppler, but it's actually the spectral Doppler. And you saw a short example before, and you make the pressure measurement. And whenever, at least in our data, have increased speeds higher than 20, although there are data in the literature describing even higher values as a mean threshold, 40 or even 50 centimeters per second as the peak systolic velocity, you will say Graves' disease. And this is what we do in the vast majority of cases with diffuse hyperthyroidism. And there is also data, and I did not, the purpose of the presentation of my talk was not about elasto. This is that we can do in another meeting if you really want. So whenever you have very stiff values, this is clearly example for subacute thyroid disease impairment. But as I mentioned in the first slide, there is a huge number of destructive type of thyroiditis, meaning hypoechoic, low flow, and no increased stiffness, in which you do not know what to do. So is there any place for contrast? And this was the question for our research. And I just give you an example. This lady, 42 years old, she had the previous history of autoimmune thyroid disease, positive diagnostic in 2011. 2013 and 17, she had a limited period of hyperthyroidism induced by choriogonadotropic hormonal stimulation for fertility purpose. She got a subacute thyroiditis in 2021 post-COVID. She got pregnancy in 2022, and during the pregnancy, she had hypothyroidism with delivery in 2022, and clinical signs and symptoms of hyperthyroidism were a positive diagnostic at the mid-2023. And then, of course, when you look to her history, actually, she had it all. She had all the variants of hyperthyroidism possible in her personal history. Grayscale imaging, transverse section, right lobe, left lobe. It's a typical clear autoimmune thyroid disease pattern. So this is clear, no doubt. So I already know this patient is autoimmune. I re-emphasize by doing this that I have a diffuse disease in front of me. When I look to the color Doppler, even if I was expecting a high flow situation, I was aiming for Graves' disease, I had a Schultz 1, so really not special increase. The spectral Doppler measurements, as you see, the flows were really, really normal. So this is diffuse clearly. This is not a Graves. This is low flow. And I said, okay, maybe I have another subacute in front of me. And when I look to the shear wave elastography, I did not get any stiff values, but soft values. And whenever you have something like this, the question from the patient point of view is, should I start antithyroid medication? Should I just control the inflammation? Should I choose the watchful waiting only? So this is why the contrast jumped into this special situation, and the research that we presented were a prospective study with more than 50 patients with diffuse hyperthyroidism. From the clinical point of view, they were not previous treated, they had no nodules, so it was a typical diffuse only overt hyperthyroidism. And of course, for the sake of the study by itself, scintigraphy was used as golden standard, because we have to have controls when you make a research. And we did it grayscale and also contrast. Actually, we did all the multi-parametric ultrasound evaluation, and we looked to the perfusion pattern. Is it homogeneous or not? The enhancement, not necessarily intensity, but also the time for enhancement and the time for wash in, wash out. And this is what is a normal thing. So when you look, the timer is there, you will, in the first 10 to 15 seconds, you will have substance in your system, but it's not very, very enhanced. And this image is stable. We can watch for this video for as many seconds as you want, but you have to trust that even in 60 seconds after, the pattern of homogeneous distribution is the same. When we also looked, and this is a qualitative evaluation, but is what you can do also, you can measure also the time, and you will get the time, where is the maximum and where is the drop, and the drop is steadily, and it's not a huge drop. You also have the variant to see that you have a diffuse type of enhancement in the system. Whenever we have, and you look here, compared with what we previous saw, it was a major enhancement. It was very early, less than 10 seconds, everything was there, and it's steady, and it stays like this, stable, more than 60 seconds. So it's a prolonged enhancement, a homogeneous and very intense one, and this is typical for Graves, meaning hyperproduction. Whenever we have a late wash-in, and look here, it's a loop, you start to have something at 7, 6, 15, 16 seconds. There is something at 20, but look, when we reach 30 seconds already, there is a mixed washout, it's starting there. So whenever you have late inhomogeneous wash-in with very quick and unstable and very quick washout, this is also very suggestive for destruction. And the same characteristic is in the previous one. We had a subacute thyroiditis. Here we have an amiodarone-induced thyroiditis, the same. At 30 seconds already, half of what we saw before of the microbubbles is gone. So we have an altered microperfusion because we have an altered capillary bed distribution. So whenever we have slow wash-in with a very quick, swift to wash out because of alteration of the microstructure of the system, it's highly suggestive for destruction. Whenever we have very fast wash-in with prolonged enhancement, long-standing, more than 30 to 60 seconds, it's highly suggestive for hyperactivity. And when we use these parameters, the diagnostic accuracy of differentiating between hyperproduction and destruction, meaning from the clinical point of view to treat or to follow, and if it's fever and pain, to give corticoids to control it, it's instant. You need less than 10 minutes to the positive diagnostic of the patient. So actually, perfusion parameter evaluation and looking deeper into the enhancement characteristic of the contrast in diffuse thyroid disease gives you added diagnostic value in understanding the underlying pathology in front of you, and has to have a place in the positive diagnostic, especially of destructive non-subacute variant of thyroiditis, which are the painless, the not necessarily amiodarone, only, let's say, iatrogenic induced hyperthyroidism and postpartum thyroiditis. And especially in postpartum variant, because you have breastfeeding females in front of you, radionuclide imaging is not necessarily the best way that you want to do. So I hope that I did open your appetite towards trying contrast in thyroid beyond just differential diagnostic of nodular pathology. And I really emphasize in starting and using this as like an instant bedside diagnostic. This being said, I thank you for your patience in being around for these minutes. Thank you very much.